In the name of Allah, the entirely merciful, the especially merciful. Key points and formulas, in critical care medicine.
Hyponatremia. It is defined as a serum sodium concentration of less than 135 milliequivalent per liter.
The serum sodium concentration can be seen as a function of the total exchangeable sodium and potassium in the body and the total body water. The formula is expressed below. Serum sodium equals sodium total body plus potassium total body over total body water. Consequently, hyponatremia can only develop because of either a loss of free water, or a gain of sodium, or a combination of both. Also, hyponatremia can only develop because of either a gain of free water, or a loss of sodium, or a combination of both.
Classification of hyponatremia. Based on the volume of the extracellular fluid, a patient can be classified into 1 hypovolemic, 2 euvolemic, 3 or hypervolemic. Causes of hypovolemic hyponatremia: loss of sodium more than loss of water, gastrointestinal fluid loss, diarrhea or vomiting. The third spacing of fluids, pancreatitis, hypoalbuminemia, small bowel obstruction, diuretics, osmotic diuresis, glucose, mannitol, salt wasting nephropathies, cerebral salt wasting syndrome, urinary salt wasting, possibly caused by increased brain natriuretic peptide, mineralocorticoid deficiency. Causes of hypervolemic hyponatremia: total body water increases greater than an increase in total body sodium. Renal causes: acute renal failure, chronic renal failure, nephrotic syndrome. External causes: congestive heart failure, cirrhosis, and nephrotic syndrome. Iatrogenic causes of euvolemic hyponatremia: total body water increase with stable total body sodium. Non-osmotic, pathologic vasopressin release may occur in the setting of normal volume status. Causes of euvolemic hyponatremia include syndrome of inappropriate antidiuretic hormone, Addison's disease, hypothyroidism, high fluid intake in conditions like primary polydipsia, or potomania, caused by a low intake of solutes, with relatively high fluid intake. Iatrogenic drugs as vasopressin analogs such as desmopressin and oxytocin, medications that stimulate vasopressin release or potentiate the effects of vasopressin, such as selective serotonin reuptake inhibitors, and other antidepressants, morphine, and other opioids. Medications that impair urinary dilution, such as thiazide diuretics. Medications that cause hyponatremia, such as carbamazepine or its analogs, vincristine, nicotine, antipsychotics, chlorpropamide, cyclophosphamide, nonsteroidal anti-inflammatory drugs. Illicit drugs such as methylene dioxymethamphetamine. Hyponatremia can be classified according to serum sodium level into severe hyponatremia, a serum sodium concentration of less than 120 milliequivalent per liter; moderate hyponatremia, a serum sodium concentration of 120 to 129 milliequivalent per liter; mild hyponatremia, a serum sodium concentration of 130 to 134 milliequivalent per liter. Hyponatremia can be classified according to clinical symptoms into severe symptoms, which include seizures, obtundation, coma, and respiratory arrest; mild to moderate symptoms, which are relatively nonspecific, and include headache, fatigue, lethargy, nausea, vomiting, dizziness, gait disturbances, forgetfulness, confusion, and muscle cramps. Hyponatremia can be classified according to duration of onset into acute, if the hyponatremia has developed over a period of less than 48 hours; chronic, if it is known that hyponatremia has been present for 48 hours or more, or if the duration is unclear. Goals of initial therapy. The treatment of hyponatremia in hospitalized patients has 4 important goals. 1. To prevent further declines in the serum sodium concentration. 2. To decrease intracranial pressure in patients at risk for developing brain herniation. 3. To relieve symptoms of hyponatremia. 4. And to avoid excessive correction of hyponatremia in patients at risk for osmotic demyelination syndrome. Goal rate of correction. Although some correction of hyponatremia is usually indicated in patients with severe hyponatremia, the goal of initial therapy is to raise the serum sodium concentration by 4 to 6 milliequivalent per liter in a 24-hour period, 0.25 milliequivalent per liter per hour.
Complications of overly rapid correction of hyponatremia is called osmotic demyelination syndrome, which was called central pontine myelinolysis. Osmotic demyelination syndrome results from damage to the myelin sheath in different parts of the brain, including pons, the basal ganglia, midbrain, and subcortical white matter. Osmotic demyelination syndrome manifests as confusion, delirium, hallucinations, balance problems, tremor, problem swallowing, reduced alertness, drowsiness or sleepiness, lethargy, poor responses, slurred speech, weakness in the face, arms, or legs, usually affecting both sides of the body. Treatment of hyponatremia. Rate of serum sodium correction. Although some correction of hyponatremia is usually indicated in patients with severe hyponatremia, the goal of initial therapy is to raise the serum sodium concentration by 4 to 6 milliequivalent per liter in a 24-hour period, 0.25 milliequivalent per liter per hour. In symptomatic patients, with acute or chronic hyponatremia, we start with 100 milliliters 3% sodium chloride solution bolus over 10 minutes to be repeated for 2 or 3 times. Then maintain the rate to increase serum sodium 0.25 milliequivalent per liter per hour. In asymptomatic patients, but with acute severe hyponatremia we start with 50 milliliters 3% sodium chloride solution bolus over 10 minutes to be repeated for 2 or 3 times. Then maintain the rate to increase serum sodium 0.25 milliequivalent per liter per hour. In patients with chronic, asymptomatic but severe hyponatremia, we generally take only those measures that are broadly applicable to all hyponatremic patients, and the maximum rate of correction should be an increase in serum sodium by 0.25 milliequivalent per liter per hour, 8 milliequivalent per liter in any 24-hour period. Hyponatremia correction. Increase serum sodium by rate, 0.25 milliequivalent per liter per hour. Sodium deficit equals target sodium minus current sodium. Total sodium deficit equals 40% body weight multiplied by sodium deficit. Hypertonic volume needed equal total sodium deficit multiplied by 1000 over 513. Time of infusion equals sodium deficit over 0.25. Rate of hypertonic saline infusion equals volume needed over time of infusion. Acute hyponatremia. Treatment setting. Patients with acute hyponatremia. Most patients with severe hyponatremia with serum sodium less than 120 milliequivalent per liter, and most patients with symptomatic hyponatremia, should be treated in hospital settings that allow frequent assessments of the patient's neurologic condition, accurate measurements of urine output, and frequent measurements of the serum sodium concentration. By contrast, patients with mild hyponatremia, and asymptomatic patients with moderate hyponatremia, usually do not require hospitalization. Treatment of patients with acute or chronic symptomatic hyponatremia. We treat these patients who have any symptoms that might be due to increased intracranial pressure, seizures, obtundation, coma, respiratory arrest, headache, nausea, vomiting, tremors, gait or movement disturbances, or confusion, with a 100 milliliters bolus of 3% saline, followed, if symptoms persist, with up to 2 additional 100 milliliters doses, to a total dose of 300 milliliters, over the course of 30 minutes. Goal of therapy is an increase in serum sodium by 4 to 6 milliequivalent per liter over a few hours. Stop all other intravenous fluid infusions. If the patient is seizing and the response to hypertonic saline infusion is delayed, you can give a rapid-acting benzodiazepine, lorazepam 4 mg intravenous. After that rapid correction we need to increase serum sodium to target level by 0.25 milliequivalent per liter per hour. Suppose the serum level is 115 milliequivalent per liter and the target is 125 milliequivalent per liter. This means that sodium deficit is 10 milliequivalent per liter. Accordingly, the total sodium deficit will be 40% of the body weight, which is 280 milliequivalent. By simple equation, this 280 milliequivalent sodium will be present in 545 milliliters hypertonic saline, 3%. Since the rate of sodium increase is 0.25 milliequivalent per liter per hour, the time of infusion of this volume 545 milliliters will be 40 hours. And this means that, the rate of infusion of this volume, will be 14 milliliters per hour. Treatment of patients with acute severe, but asymptomatic hyponatremia. We treat asymptomatic patients with a 50 ml bolus of 3% saline, hypertonic saline, to prevent the serum sodium from falling further. We then monitor the patient for symptoms, and remeasure the serum sodium concentration hourly, to determine the need for additional therapy. However, we do not give these patients hypertonic saline if the hyponatremia is already autocorrecting due to a water diuresis. After that rapid correction, we need to increase serum sodium to target level by 0.25 milliequivalent per liter per hour. Suppose the serum level is 115 milliequivalent per liter and the target is 125 milliequivalent per liter. This means that sodium deficit is 10 milliequivalent per liter. Accordingly, the total sodium deficit will be 40% of the body weight, which is 280 milliequivalent. By simple equation, this 280 milliequivalent sodium will be present in 545 milliliters hypertonic saline, 3%. Since the rate of sodium increase is 0.25 milliequivalent per liter per hour, the time of infusion of this volume 545 milliliters will be 40 hours. And this means that the rate of infusion of this volume will be 14 milliliters per hour. Chronic asymptomatic hyponatremia. In patients who are asymptomatic, or have mild to moderate symptoms, as headache, fatigue, nausea, vomiting, gait disturbances, confusion. And those who have moderate hyponatremia, with serum sodium, 120 to 129 milliequivalent per liter, we generally take only those measures that are broadly applicable to all hyponatremic patients, as to identify and discontinue drugs that could be contributing to hyponatremia. Identify and, if possible, reverse the cause of hyponatremia. And limit further intake of water. Fluid restriction and other treatments. Fluid restriction to below the level of urine output is indicated for the treatment of symptomatic or severe hyponatremia in edematous states, such as heart failure and cirrhosis, syndrome of inappropriate antidiuretic hormone, SIAD, advanced kidney impairment, and primary polymorphia. In patients with a highly concentrated urine, 500 mosmol per kilogram or higher, fluid restriction alone may be insufficient to correct hyponatremia. Depending upon the etiology of hyponatremia, other therapies may include loop diuretics, oral salt tablets, urea, potassium supplementation, vasopressin receptor antagonists. Treat the underlying cause. In addition to the specific therapies that are aimed at correcting the hyponatremia, therapy should also be directed at the underlying disease. Let us discuss hyponatremia in these two examples: SIAD and heart failure. SIAD, syndrome of inappropriate antidiuretic hormone secretion. This is a condition where inappropriate secretion of antidiuretic hormone despite normal or increased plasma volume causes impaired water excretion by the kidney, leading to hyponatremia. SIAD is a diagnosis of exclusion, as there is no single test to confirm the diagnosis. Patients are hyponatremic and euvolemic. Causes of SIAD include any central nervous system disorder, ectopic production of antidiuretic hormone, most commonly cell carcinoma of the lung. Drugs, carbamazepine, oxcarbazepine, chlorpropamide, and multiple other drugs. HIV. Pulmonary diseases, pneumonia, tuberculosis. Postoperative patients, pain medicated. Treatment includes fluid restriction and the use of vasopressin 2 receptor inhibitors. Heart failure. Loop diuretics will also decrease tonicity in the renal medulla and facilitate increased free water excretion. Loop diuretics represent the first line of management in dilutional hyponatremia of acute heart failure. The effect of angiotensin-converting enzyme inhibitors effect is due to enhanced cardiac output, and via their arginine vasopressin antagonist activity in the collecting ducts, they increase the ability of the kidney to excrete diluted urine. Currently, there is no evidence to support the use of hypertonic saline in heart failure patients with hyponatremia without neurological symptoms. The European guidelines for the management of hyponatremia with severe symptoms recommend an infusion of 50 milliliters of 3% hypertonic saline over 10 minutes to be repeated every 10 minutes with maximum dose 150 milliliters, to a goal of 5 milliequivalent per liter increase in serum sodium in the first hour. Further management guided by clinical and laboratory response. Correction should not exceed 0.25 milliequivalent per liter per hour. The same, as we have mentioned before. However, the additional sodium load provided using hypertonic saline in heart failure patients could worsen their symptoms. Therefore, hypertonic saline treatment should be reserved only for patients with severe neurologic symptoms, in which benefits of immediate treatment to decrease neurological dysfunction outweigh the risk of congestion. In addition, concurrent infusion of loop diuretics such as furosemide is also suggested when heart failure patients are with hypertonic saline solution. When renal replacement therapy is indicated in subjects with diuretic refractoriness, advanced chronic kidney disease or severe acute kidney injury, careful serial sodium monitoring during dialysis must be ensured to avoid rapid correction of serum sodium. Thank you. If you want more data, you can open achmedaglan.com website.